Hey everyone, my name is Missy Henke. I'm the medical director of the Heartview Foundation. We are all going to be working together on a grant to provide services to our opioid use disorder patients here in Bismarck and the surrounding areas. So this will be the first of 3 talks that I'm going to record for you, basically to kind of give an overview about medications for opioid use disorder, as well as Heartview services and the grant and what this all looks like for all of you. This first presentation is pretty much just going to cover the basics of addiction, how it affects the brain, why these medications work, why it's so important, why we're having these conversations. And then from here, the follow-up presentations will get more into the nitty-gritty, what this is going to look like moving forward. So let's get started. Okay, so this first presentation is basically going to be an introduction to addiction. So this is basically a little outline. We're going to talk about kind of addiction 101, and I'm not trying to insult anyone's intelligence here. You're all very smart. I certainly understand that, but I also think it is helpful to talk a little bit about what actually happens at the neurochemistry level. We'll talk a little bit about why opiates are special, and then the mortality, why we use these medications, and then at the end there's just a few very simple questions that part of the grant, we want to make sure you watch the videos and answer the questions. So the neurochemistry of addiction, when we talk about addiction and brain circuitry, and we talk about addiction being a disease of the brain, it is actually the limbic system that we're primarily talking about. So our limbic system is responsible for our perception of emotions, both positive and negative. I put this slide on here of 9/11 because when my kids look at this slide, they always say, oh yeah, mom, that's 9/11, right? Okay, but when I look at this slide, I remember 9/11, right? I remember how it felt. I remember being angry. I remember being scared. I remember the uncertainty, all of those things. So when I look at this picture, I kind of feel this picture. And that's really what our limbic system does. It ties sights, sounds, smells, and it connects it with emotions and memories. So if you think about that, if there was a certain food that your grandma used to make when you were a child, and now grandma's gone, or grandma's in a nursing home, if you smell that food or think about that food, it connects you to your grandma. Like you have those memories. It's almost a visceral response. That's what our limbic system does, right? With music, we hear a song that maybe we danced to our spouse with at our wedding, and then all of a sudden we go back to that day. That's our limbic system. So controls and regulates our ability to feel pleasure, which motivates us to repeat behaviors that we need to survive, right? So things like eating, drinking, sex are all hardwired for our species to survive. And so when we do those things, our brain gets a feel-good chemical, so we do those again, which is sort of like when we see with dementia, as the limbic system starts to get eaten away, people stop eating because we don't get any of those feel-goods. We don't have those basic survival skills. So healthy life-sustaining activities, but also drugs of abuse. And then dopamine is the key neurotransmitter in the limbic system that we're talking about. So it regulates movement, emotion, motivation, and feelings of pleasure. Again, drugs of abuse target the brain's reward system by flooding the circuit with dopamine. So when that reward circuit is activated, like I was talking about, then the brain triggers a memory and teaches us to repeat that behavior. So what that means is, like, if I use a substance and I get a little bit of dopamine, my receptors get a little bit excited about that, and it creates a memory, and it's a very positive memory. So how much dopamine are we talking about? Well, an average brain just sitting here, probably 50 nanograms. But sex takes that to about 125. But look at heroin and methamphetamine. So what that means is that when I use meth or heroin, my brain gets bathed in dopamine, and it just lights up all the pleasure centers in my brain, creates this tremendously positive memory, and ties all of these great emotions to that. The problem that we have with that is, as we continue to expose our brain to these high levels of dopamine, our brain naturally is going to downregulate the amount of dopamine that it produces. Also going to cut back on our number of receptors, right? Because it's overstimulating. So with less receptors, what that means is our ability to experience pleasure is reduced. So let's say I'm using meth, 1100 nanograms of dopamine all over my brain, and then I stop using meth, and all of a sudden I'm not at 50 anymore. Now I might be at 30 or 20 or 10. Well, if dopamine is a feel-good chemical, I don't feel good. So what that means is my brain is going to say, oh, Missy, remember how good methamphetamine felt? You should just use that one more time to kind of get the house cleaned and to feel good. But unfortunately, then I use again and I get that bath and that feel good and then depletes again. So what this does is it just leads to ongoing drug abuse in order to try and increase those dopamine levels, right? Like no meth addict is going to tell you that's what they're trying to do. But internally, that is what their neurochemistry is trying to do, is increase the levels of dopamine. And again, you all know this, but like the withdrawal from any substance is the opposite of the intoxicating effects. So the only reason I wanted to talk about this is because there's that very, very acute physical withdrawal, right? We all know what it looks like. It's the nausea, vomiting, diarrhea, sweating, irritability, agitation, restless legs, all of those things. But what I wanted to talk about was more of the subacute opioid withdrawal. And this is more of the mental opioid withdrawal that can go on for 3, 6, 9, even 12 months of just depression, anhedonia, I can't sleep, I can't think, nothing feels good. And this is that chronic dopamine depletion. Again, we get the physical withdrawal, but that doesn't last that long, right? We could survive that. We could incarcerate our way through that. The problem is this longer withdrawal that goes on for months. And this is the piece that even if someone is incarcerated or hospitalized and they come out and they're like, yeah, I no longer have the cramps and the diarrhea, but man, I just don't feel good. That's from that dopamine depletion. And again, that's why people that are incarcerated for 6 months come out and the first thing they do is go use drugs because they want to feel better. When we talk about the opioid epidemic, and of course, we've all been hearing about it for decades now, really. So it kind of started with prescription pills, right? We knew this, Purdue Pharmaceuticals and all of those things, right? We started with that. Then the problem was, as prescribers, we started cutting back. Like, whoa, wait a minute. Everyone's getting too many opiates, right? So in 2012, there were 259 million prescriptions for opioids in this country, which means every American adult could have their own bottle, right? So not surprisingly, we figured out that was a problem. So we cut back on prescribing, but it's supply and demand, right? We created a demand and then we cut off the supply. So people switched to heroin because it was cheaper and it was easier. And you can see in that bright blue line is heroin. But then what we really have is this third spike, the purple line, which is synthetic opiates. And that's really what is driving the opioid epidemic now is the synthetics. So what is fentanyl? Again, 50 to 100 times more potent than morphine. Since 2016, more overdose deaths were due to fentanyl and other synthetics than any other type of opiate. If we look at from 2013 to 2019, the increase in deaths related to synthetic opiates has increased 11-fold, right? And from 2019 to 2020, we have again another increase. So these are overdose deaths just involving fentanyl, and this is over a 3-month period. And the numbers aren't that important. I want you to look at how this is spiking. And again, this really ends in 2017. So when we talk about from 13 to 19, there was an 11-fold increase. That trajectory is really going off the chart. And I would argue that it's not sustainable, right? And again, if we hadn't been flooding the streets with Narcan in the last 10 years, these numbers would be absolutely unbelievable. So when we talk about all opioids from 1999 until 2020, you can see in 1999 we were less than 10,000. Now we're at 68,000 people in 2020. And again, of course, the pandemic we all know was not kind to mental health or substance use. But if you look at this from 2019 to 2021, we saw a 39% increase in all drug overdose deaths. And again, this is all comers. This is not just opiates. This is all of the things, right? But 39% increase in 2 years. And we know that 70 to 80% of drug overdoses are related to opioids, right? So again, opioids are driving this overdose epidemic. 275 people die every single day from a drug overdose. So during this talk, 4 to 5 people are going to die. Of course, not all in Bismarck, but they're going to die around this country. And it's all socioeconomic classes, it's all races, it's all genders, it's all areas, it's rural, it's urban, it's all of the things. So it really is impacting everyone. And again, we're about 5% of the world's population. We claim about 27% of the world's overdose deaths. NIH calculated more than 100,000 people died of drug overdoses. And again, this is not just opiates, this is all comers between May 2020 and April 2021. Compare that to the 58,200 people who died during the Vietnam War in 20 years. And AIDS at the peak of the epidemic, which some of you are probably too young to remember. I was going to college at this time, so very acutely remember this, 43,000 people died during the peak of the AIDS epidemic. And then in 9/11, again, going back to that, we lost almost 3,000 people on that day. We have a 9/11 about every week and a half when it comes to drug overdoses. So certainly it is a significant problem, and it should be garnering the attention that it is getting. This is why we have medication-assisted treatment, right? And again, medication-assisted treatment is not medication replacing treatment. It is not me giving a medication so that someone can continue to do the things that they're doing. It's me prescribing a medication and working with LAC psychologists, licensed professional clinical counselors, nurses, techs, all of those people to give the wraparound services that we have with other illnesses in medicine, right? Like we get this sort of full court press when someone has coronary artery disease or cancer or we have navigators that help people to navigate the medical profession with these other illnesses, but we really don't when it comes to a substance use disorder. So why do we have medication-assisted treatment? Well, guess what? People survive. They stay in treatment longer. It should be not a surprise that the longer you stay in treatment, the more likely you are to stay clean, right? That's with anything. If you have a diabetic and they go somewhere to get well for 28 days, no one expects them to leave and be cured of their diabetes. So it's unreasonable to think that someone's going to go to treatment and come out and be free of their illness, right? So decreases drug use, decreases hepatitis, HIV, decreases criminal activities, increases employment. And for moms with an opioid use disorder who get put on MAT, they do better and so do their babies. So what meds are we talking about? We're talking about methadone, buprenorphine, which is Subutex and Sublocade. Then we have buprenorphine combined with naloxone, which is Suboxone and Zubsolv. And then we have naltrexone, right, which is Revia, which is an oral medicine, and Vivitrol, which is injectable, and then Narcan. So with methadone, right, it's the gold standard because it's been around the longest. Been using it since our second opioid epidemic in this country, which was actually the Vietnam War, right? We're actually in the middle of our third opioid epidemic right now. Only available through an opioid treatment program when using it to treat an opioid use disorder. Of course, you can use methadone for pain, but if you're using it to treat someone's substance use disorder, it is only available through an OTP. Federally regulated, state regulated. We were the 49th state to get OTPs. Wyoming is the only state that does not have them. And the first OTP opened in Minot in North Dakota in 2016. Heartview opened in 2016. There's also one in Fargo and soon to be one in Grand Forks. It is a full mu agonist. So what does that mean? And again, this is my little cheap graphic here. If this is your opioid receptor, right? And I take heroin or fentanyl or oxy or something like that, binds to the receptor, I get the downstream release of dopamine, lights up the pleasure centers in my brain, right? Methadone binds in much the same way. It's a full agonist. So it sits on that receptor, but because it has such an extremely long half-life, it binds really slowly. It also binds very strong. So if someone is taking their methadone every day and the methadone is sitting on their receptors and then they go out and use heroin, the methadone will hold its place. So they won't get the same experience that they normally would have with the heroin. So it can be actually a deterrent effect as well. Higher doses are most effective at reducing heroin use, so usually 80 to 150 milligrams. Now, I have people that are stable on 25 milligrams, and I have people that are stable on 290 milligrams. Of course, we don't start there, right? There's a lot of rules that go along with methadone, which is why it has to be out of an OTP. So good outcomes are contingent on length of treatment, as they are with everything in medicine, right? And we don't treat diabetes for 6 months, and we don't treat cancer for 2 months. We treat for the duration of the illness, right? So patients who stay in MAT with methadone for less than 3 months show little or no improvement at a year compared to people who never had MAT, right? After several months, though, the use of illegal opioids drops to about 80%. And again, the vast majority of people who leave an OTP and pursue no additional treatment will relapse. So take-home doses, and I added this because there's some misperceptions out there about an OTP that people enroll with us and then we just give them their take-homes. And I talked to a hospitalist who said, well, yeah, they're on your take-home program. And I was like, yeah, we don't have a take-home program, right? They have to meet these rules in order to get take-home doses. So we have people that have been dosing in our clinic for a year and don't have any take-homes because they can't meet these basic criteria, right? If you can't keep your meds safe, if you're homeless and you can't keep your meds safe, you don't need a take-home dose, right? If you're taking on new criminal charges, you don't need a take-home dose because your behavior doesn't demonstrate that you can be trusted with that, right? So just so that you all understand, with methadone, they have to earn the right to have take-home doses. And it's a long road. They have to dose for 2 years before they can have a month's supply of medication. So again, when people talk about methadone, like, oh, it's just an easy way out. Well, I would argue that if I had to be somewhere 7 days a week for 90 days before 8:45 in the morning, I would struggle. 6 to 8:45 is our dosing window, right? So if they show up at 9, they don't get dosed that day. They don't get a day off until they've been there 90 days, and then they get 1 day off a week, right? So at a year, they get 13 take homes. I mean, it's certainly not easy, but it's also much easier than trying to live on the streets and live in addiction. So switching gears then to buprenorphine. So Subutex is buprenorphine alone. Initially was considered safer in pregnancy. Newer data says maybe not so much. So I still switch them to buprenorphine alone, but the data doesn't necessarily say that you have to anymore. Suboxone combines buprenorphine and naloxone. The naloxone piece is really only in there to prevent people from injecting it IV. So its bioavailability is very poor when taken sublingually. So that's the only reason it's really in there. And Zubsolv is the same medications, it just tastes better. And it's not currently on anyone's preferred formulary, so you're not going to see a lot of that. Sublocade actually is a once-a-month injectable buprenorphine only product. Given sub-Q, so more like an insulin shot into their abdomen, pretty easy. They just have to stabilize on the sublingual product for a week and then transition to the Sublocade. So it's great because there's not a lot of diversion potential with Sublocade. The issue is it's exceedingly expensive, somewhere around $1,500 a month, and we have a hard time getting insurances to pay for it. But again, it's a great option, and I know they're starting to use it in the DOCR, which is awesome. And then Probufene, we don't really use it surgically implanted. There's a lot of hiccups with that. Approved in October of 2002. Again, this is a partial agonist. So if this is your opioid receptor and this is oxy, right? So I think of like buprenorphine sort of half sits on the receptor. So you don't have the cravings and the withdrawal that come with being a naked receptor, right? So it kind of half sits on there so that you don't have the cravings, you don't have the withdrawal, but it also doesn't bind in such a way that you get that euphoria. So less likely to be abused, less likely to have side effects. And it is an office-based practice. So you do not need to be an opioid treatment program, which is the big benefit to buprenorphine. And the rules were changed with this latest administration so that there can be more providers, which is why we're here talking to all of you. So again, when we talk about dopamine levels, right, and we look at buprenorphine and methadone, they both raise dopamine to normal levels, right? Because that's one of the things that people say, well, they're just getting high in their methadone, they're just getting high in their Suboxone. Well, actually, they're not, because the high comes from the dopamine. And this is really just bringing it back to normal. So that subacute withdrawal that we talked about, where they're profoundly depressed and anhedonic for months at a time, that really goes away. And so the beautiful thing about medications, opioid use disorders, what it does is it allows your brain to engage in treatment, right? So it stops the obsessing, it stops the compulsive behaviors so that they can actually engage in treatment. Because patients with low dopamine levels have extremely low retention rates for treatment. Less than 10% of them will stay in treatment because they feel miserable. I mean, recovery, everyone says recovery is great. And then they start living a life of recovery and it's terrible. So they don't stay, right? So again, this is just a tool to keep people in the chair so that they can get the rest of the tools that they need to be sober. The mortality rate for patients who pursue abstinence-based recovery is 10 times higher than for people who get MAT. So again, we're talking about a life-saving treatment, right? Again, when we look at that trajectory of what's happening with our opioid overdose rates, we have to do something different. And of course, we know that MAT combined with psychosocial treatment is superior to either the drug or psychosocial treatment alone, right? Because the same thing with medicine. Like if you get insulin, but nobody tells you how to take it or why it's important or how to maintain your diet, you don't do well. Yeah, I got my insulin, but I don't know what I'm doing with it, right? But if someone tells you like how to manage your sugars, but they don't give you the insulin, that doesn't work either. So you have to have both. So again, that's kind of the end of the talk. These are just some questions that you guys are going to have to answer. So which area of the brain is primarily affected by SUDs? Again, is it the hypothalamus, the limbic system, cerebellum, cerebrum, or the pituitary gland? I'm not going to tell you the answer. What is the primary neurotransmitter affected by SUD? Dopamine, serotonin, glucosamine, and acetylcholinesterase. Which opioid is contributing to the increase in overdose deaths? Is it oxycodone, hydrocodone, fentanyl, methadone, or heroin? Last one. What happens with dopamine levels in MOUD? They double from baseline, nothing. They return to baseline, or similar to what happens with heroin. So those are your 4 questions. Again, there are 2 more presentations coming, and I will absolutely make sure that all of you have my contact information so that we can, again, this is all new to all of us. So we're kind of just doing the best that we can. So we have no idea what kind of questions are going to come up, but we want to make sure that you know that we are absolutely available to you to get you through any bumps in the road. So that's the end of presentation 1, and next one is coming soon.